We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. My name is Theresa Human. I'm a medical science liaison with Cumberland Pharmaceuticals, and today I have with me Dr. Micah Jacobs. Dr. Jacobs is an infectious disease physician and managing partner of Romano Pontzer and Associates, which is a private infectious disease group out of Pittsburgh, Pennsylvania. Thank you for joining us today.
Thank you, Theresa. Pleasure to be here.
Let's review the case. Ann W. is a 70-year-old female who's hospitalized for a recent fall. On hospital day 5, she develops a fever and is started on vancomycin and cefepime. 48 hours later, she's showing no improvement. Increased oxygen support is required. She's transferred to the intensive care unit and intubated for respiratory failure. She's febrile and has an elevated white count and procalcitonin level. Following intubation, chest x-ray shows left lower lobe consolidation indicative of pneumonia. Sputum cultures reveal MRSA with an MIC equal to 1 to vancomycin. On ICU day 2, the patient is not improving clinically and is subsequently changed from cefepime and vancomycin to telavancin. On ICU day 5, the patient is transferred to the medical step-down unit with minimal O2 requirements and is treated for a total of 10 days with telavancin. Dr. Jacobs, can you tell me about the challenges in treating patients with healthcare-associated or ventilator-associated pneumonia?
Yeah, thanks, Theresa. When we're dealing with patients who have been in the hospital for some period of time, it does become a little bit more challenging to treat pneumonia when it develops, whether or not they're on a ventilator. One of the big issues is these patients are more likely to have more drug-resistant bacteria associated and more hospital-type acquired bugs. So we do start to worry about more Staph aureus and MRSA, as well as things like Pseudomonas that come in. In addition, these patients oftentimes will have been on some antibiotics already, which may lead to some extra drug resistance. And with the development of the pneumonia, which can be quite serious in a patient who's already somewhat compromised from being in the hospital for whatever other reason, their immune system may not be functioning quite as well. We therefore really need to be very active and aggressive with our antibiotics in order to ensure that we're getting good penetration. So that antibiotic selection becomes very vital to ensure that we are getting the optimal efficacy so we can get this pneumonia treated as quickly as possible.
So what are you looking for in an antibiotic then when you're choosing either empiric or specific therapies?
Yeah, so the key things, first of all, is I want to make sure I have antibiotics that appropriately cover the, from an empiric standpoint, the likely organisms that are going to show up, and from a targeted standpoint, that definitively cover the organisms we have isolated. But just as important, I need an antibiotic that has good penetration into the lungs, since we're dealing with the specifics of lung tissue, and also has rapid activity. One of the biggest problems we sometimes run into is it takes a little while for certain antibiotics to truly penetrate into all spaces. So while the antibiotic may be fully active, if it hasn't truly gotten to the location of the infection within a short amount of time, then we're giving the infection time to really get ahead of us. And our goal with our antibiotics is making sure that we're there and we're there rapidly so we can get the infection to stop and start reversing the effects.
In this case, the patient was not clinically responsive to initial empiric therapies. In your practice, how long do you typically wait and look for clinical improvement before you choose to change antibiotics?
Yeah, that can be a very patient-dependent situation. But in general, what you want to see is an antibiotic that is starting to show evidence that it is working within about 24 hours of being started on a patient. It oftentimes may take 48 or 72 hours to see complete, true turnaround, but you want to see evidence that the patient is starting to improve with your choice of antibiotics on board. You're going to want to see that the fevers have started to come down at least a little bit and that they're not getting worse. Ideally, you're going to want to see the white blood cell count starting to improve. And if you're seeing a patient that's actually worsening after 24 hours, it is very reasonable to question whether your antibiotic has the right spectrum of activity or whether it's truly getting to where it needs to be to fight off the infection.
This Infectious Insights series is brought to you by Cumberland Pharmaceuticals.